Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is September 5th, 2025. This video is in a JAMA article published online August 31st, 2025, titled Semaglutide with Tirzepatide in Patients with Heart Failure with Preserved Ejection Fraction, or HFpEF. HFpEF is increasingly common, especially in patients with obesity and type 2 diabetes. Prior randomized controlled trials, STEP-HFpEF, DM, and Summit have suggested benefits with GLP-1 agents, Semaglutide and Tirzepatide, but lacked robust clinical endpoints. The objective was to evaluate real-world effectiveness and safety of Semaglutide and Tirzepatide in patients with cardiometabolic HFpEF. Design 5 active comparator cohort studies from 2018 to 24 across 3 major US databases: Medicare, MarketScan, and Optum. They emulated randomized controlled trials followed by expanded eligibility cohorts. Sample size: semaglutide versus sitagliptin, N was 58,333. Tirzepatide versus sitagliptin, N was 11,257. Tirzepatide versus semaglutide, the number was 28,100. Statistics: propensity score overlap weighting, Cox proportional hazard models, Kaplan-Meier survival curves, and fixed effects meta-analysis. Demographics: mean age 66.7 to 70.8 years, 54% were female. Mean BMI was 36 to 40.2. High burden of hypertension, type 2 diabetes, CKD, obstructive sleep apnea, and AFib. What did they find? Semaglutide versus sitagliptin, hazard ratio 0.58, 42% lower risk of heart failure hospitalization or all-cause mortality. Tirzepatide versus sitagliptin, hazard ratio 0.42, 58% lower risk of heart failure hospitalization or all-cause mortality. Tirzepatide versus semaglutide, hazard ratio 0.86, no meaningful difference. Limitations: non-randomized design, reliance on claims-based diagnosis, medication adherence unverified. Key takeaways: both agents significantly reduce clinical events in HFpEF with obesity and type 2 diabetes mellitus. Real-world evidence complements randomized controlled trials, supports broader use in clinical practice. Head-to-head comparison showed no superiority of tirzepatide over semaglutide. Clinical pearls: GLP-1 agonists in HFpEF. 1. Early impact. Cardiovascular benefits appeared within 3 months before full dose titration or significant weight loss. Real-world validation. Robust real-world data. N was more than 97,000. Complements STEP-HFpEF and Summit randomized controlled trials. Broad applicability. Benefits consistent with age, gender, BMI subgroups, suggesting wide generalizability. No superiority. Tirzepatide was not superior to semaglutide. Clinicians can choose either confidently. Safety first: no substantial increase in GI events, infections, or other safety concerns observed. Practice ready: study supports integrating GLP-1s into HFpEF care for patients with obesity and type 2 diabetes mellitus. Number needed to treat matters. Now, the number needed to treat was 31 for semaglutide, 26 for tirzepatide. Clinically meaningful. Propensity power. Overlap weighting and benchmarking strengthen the validity of these findings. Claim-based precision. HFpEF was defined using validated algorithms with positive predictive value around 91%. And the 10th point, supports the expanding cardiometabolic utility of GLP-1 agents beyond glucose lowering. Eponyms related to this trial: STEP-HFpEF, semaglutide treatment effects in people with obesity and HFpEF, key randomized trial in the study for benchmarking semaglutide outcomes. Summit trial, study of tirzepatide in obesity-associated HFpEF, provided foundational evidence for tirzepatide in HFpEF and also emulated here. TCOS trial evaluating cardiovascular outcomes, gliptin, used to justify sitagliptin as a placebo proxy, showed to have no heart failure benefit. Select trial, semaglutide effects on cardiovascular outcomes in overweight or obese patients without diabetes, not directly emulated, but cited to support early onset cardiovascular benefits of semaglutide. Framing criteria not named directly in the paper, but implicitly referenced via use of HFpEF diagnosis from administrative claims. RCT, Randomized Controlled Trials Duplicate Initiative, a methodological eponym for trial emulation using real-world data, developed by Schneewies et al. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.